Hi, I'm Eduardo Saad from Rio de Janeiro, Brazil. It's a pleasure to be participating in this Fluoroless session. I'll be talking about tips and tricks, zero fluoro AF ablation. No conflicts of interest for this presentation. So the bottom line question is, why do we rely on fluoroscopy? Uh, yeah, actually, clearly, fluoroscopy is the gold standard for most EP physicians. We were all trained in fluoroscopy. We have comfort in believing that we know what the catheter is or believing where the catheter is going and seeing where the catheter is going with fluoroscopy. Although I have to recognize that fluoroscopy is, besides the radiation part of it, which is very important, as has been uh, talked before, fluoroscopy is really a 2D imaging modality that has not much detail about it. So we see catheters moving in, and we don't really know detail about the structures that we are uh, navigating, but this is the gold standard that we all, the image model that we all are comfortable with. Although I have to say we have much better technology nowadays. This is the new Carto system, the right atrial mapping of a focal tachycardia. This is the new Insight system of a reentrant tachycardia, biatrial mapping, not only in terms of mapping and delineation of the arrhythmia mechanism, but the anatomy can clearly be much better depicted on a 3D mapping system than on fluoroscopy, as well as the navigation of catheters. And that, in conjunction with intracardiac echo, makes the platform upon which the zero fluoro procedures are based. In fact, intracardiac echo is so important that we have a joke saying that really needs to be our eyes, because we can see, this is the only way you can see the real anatomy in real time. And it's amazing how much detail we can have on nice procedures. This is an editorial from this year from Dr. Versmin and Dr. Paul Zai, and I fully agree that fluoroless catheter procedures is a change that is inevitable. We have to embrace it. It's good for everyone, good for the patient, good for the doctors, good for all the healthcare team involved in procedures. And I think that the learning curve is something that we need to pass, but it's very doable, and it's clearly the way to go. For me, I've always been a nice user. It's been almost 20 years that I use ice, but in conjunction with fluoro. And in 2016, I for the first time in an EP Life procedure, I saw Rodney Horton in Austin doing a fluoroless case. And this is the message in Portuguese that I sent to my team. Say, listen, I just saw a completely fluoroless AF procedure. I was shocked and amazed. And I said, we need to do it. And then a few months later, there I was in Sheffield Doshie's lab in California. I spent a couple of days there, and again was amazed by the fact that he could do it entirely fluoroless and very, very easily and safely. Until also I started doing cases, and I think I've earned a more degree, a better degree, what Dr. Resminia calls a black belt, once I visited his lab earlier this year. Not only because he showed me more complex ice skills, but also he's a great host, and he showed me, introduced me to Persian food. It was that was an amazing visit, and changed really my view of a lot of things in the fluoroless procedures. So there we are. This is our lab. Everyone is comfortably not using lead, and we have fluoro only as a backup for our ablations, our zero fluoro procedure now for almost 2 years. Uh, I think we rely heavily on innovation, and fluoro reduction techniques is a must in EP. It's an innovation that I cannot speak highly enough. This year, I had the opportunity to publish our first series, 95 patients of SVTs, using this combination of ICE and 3D mapping to do cases, ablation cases. Now, we're going to report at the LAHRS meeting 181 supraventricular arrhythmia procedures. And this is we have more than 200 cases now, and we're very comfortable, and we're trying to spread the word out in several different media and publications. But the procedure starts with vascular access, and ultrasound is the way to go here as well. So it's unacceptable today in 2020 to have growing hematomas of this fashion because of arterial puncture. Because the ultrasound, we can see everything. So this is a Doppler ultrasound of the femoral artery and vein. The artery is pulsatile, the vein is more of a continuous flow, the vein here is compressible. So once with the transducer, you compress the vein, the artery is here pulsating, and we can see that on an axial view or on a longitudinal view. And here we can see a wire already in the vein on the longitudinal view, and another needle coming in for the second puncture. And we can see the track to the needle, and can watch it all the way until it reaches the vein. Here the vein is compressible again. So we have a lot of precision within ultrasound. Once you have access, our eye scatter is the first one to go in. And as long as we are in the lumen, you're going to see this echo free space near the probe tip. And as long as you have this free space, you can actually advance the catheter. If you have a wire in the vein, even better, you can follow the wire. But as long as you have free space at the tip of the catheter, we can advance it safely. So here is advancing over the IVC. This is the echo free space, advancing the catheter easily until it reaches the IVC RA junction. And then here you may have to do somewhat of an anterior tilt if you have too much of a bend, but easily going in the right atrium to the home view of the echo, intracardiac echo standard views. We like to take a look at the RA and the left atrium. Here, the left atrial appendage and the mitral valve, and we know what kind of substrate we're dealing with. In the left atrium, here's a lot of smoke, slow flow. We need to give heparin and reach a high ACT before we go transeptal. We also like to go across the tricuspid valve in the RV with the eye scatter. It's very easy to do, so we can have not only an anterior view of the pericardial space, but also a posterior view, posterior to the LV, to make sure we don't have any baseline pericardial effusion. And also, if you have any doubts about whether you have thrombus or not in the left atrial appendage, we move in. This is the pulmonic valve and the pulmonary artery. Put the catheter there, and we can see the distal tip of the appendage in this fashion. This is the pulmonary artery. This is the appendage seen from upside down. So this is a fluoro shot showing a contrast in the left atrial appendage. You can see how close the eye scatter is to the distal part of the left atrial appendage in opposition to the TE probe, which is far away from that. So the TE can see really well the proximal part, but the eye scatter and the PA can see very well the distal left atrial appendage. And in case we have doubt, this is how we do it. So once there, we advance a wire to the SVC using a long sheet for placement of the catheter. So this is a wire clearly seen going in the superior vena cava. Once it's in there, the sheet is advanced over the wire, and as it advances, you kind of covers the wire, if you will, so we don't see the wire on the part that's covered by the sheet. Once the sheet is in there, you can inject some saline, make sure you're in the SVC, and it's very important to differentiate what's SVC, what's right atrial appendage, because if you put a wire in the appendage and advance the sheet, you can have a perforation. So very, very precise what you can see. So now the catheter is being advanced over the long sheet, and I like to see it on ice. So I wash the tip of the sheet on ice, and I leave some space so the catheter doesn't come in a position and doesn't create force on any walls. So we earn the lumen, and once it's out of the lumen, we know that we lose the black mark on the tip on Carto. If you're using Carto, if you're using Insight, you see the impedance drop. And here you can see the starts mapping the right atrium, here the fossa, and we start creating geometry in matrix if we're using Carto. Here the CS cannulation. Here's the left atrium, the CS in an axial view, the catheter going in the CS. Here in a longitudinal view, the CS and the catheter going in to the more distal CS, so we can cannulate and mark that on the mapping system. I like to use a duodeca catheter coming down from the jugular vein. So this is the SVC, the catheter going down. And here's, in fact, the duodeca catheter cannulating the CS. So we mark the CS, already created the geometry. You don't need the whole right atrial geometry, just the parts that you need. This is the CS, and the cannulation of the CS very easily without using fluoro. So next step is the transeptal axis. So coming down from the SVC towards the septum and the fossa, tenting the fossa. Once you're in the left atrium, a wire is put out of the dilator, advancing the wire. Everything is over the wire, so don't have to advance the sheet there directly. So here the transeptal puncture, you see the needle clearly going in the left atrial cavity after perforating the septum. So the wire is advanced to the pulmonary veins, and you see that this wire, whatever is covered by the sheet is inside the sheet, so you know what the sheet is. So here, if you pull back the sheet, you see the wire in its entirety. So from the septum to the pulmonary veins, the left pulmonary veins, and then you can advance the sheet. And as you advance the sheet, you cover the wire, and you know so where your sheet tip is based on the wire, how much wire you have, a brightness of the wire. So next step, here is the sheet going in. So again, you know the sheet is in the left atrial cavity. And after the sheet is there, we watch the catheter coming up. This is the HD grid catheter going in the left atrial cavity and clearly seen on ice to start mapping. This is the second transeptal axis, the assembly coming down from the SVC again to tent the septum. And here is already the two sheets in the left atrial cavity going across the septum. Once there, we start mapping, and eyes can clearly see the mapping and the catheter contact. So here it's a pentaray catheter going in the left inferior pulmonary vein. Here's mapping the ridge between the left upper pulmonary vein and the left atrial appendage. Here the pentaray is going in the left atrial appendage and mapping the the mitral annulus. So everything is clearly seen, and we can see the contact and make sure that our mapping is very, very accurate. You can, of course, you always follow that on the 3D mapping system as well. So in the standard fashion, so this is the left pulmonary vein reconstruction, the upper and the lower vein in two different views. This is the PA, this is the superior view. So posterior wall, right upper pulmonary veins. So in a standard fashion. So we clearly reconstruct and take advantage of the capability of the 3D mapping system to reconstruct. We liked to go with the eyes to the left atrial cavity. So after the second transeptal, leave the wire in there, follow the wire, and then get the eyes tip inside the left atrial cavity. With that, this is a more complex type of procedure, but this is what gives you full HD pictures. This is the left pulmonary veins with Doppler flow. This is the right upper and middle pulmonary vein. So clearly delineation of the anatomy, right inferior with early branching. So eyes in the left atrial cavity, you can have nothing in between your probe and the structure of interest. So you clearly see beautiful full HD pictures. Then we proceed with ablation in a standard fashion. So contact force guided ablation, the standard way, circumferential pulmonary veins, whatever set of lesions you want to do. But again, looking in eyes, eyes can clearly see the tissue changes that happen during the ablation. This is the tip of the sheet, tip of the catheter in the ridge between the left upper and left atrial appendage, ablating the roof of the left atrial and the left atrial veins, right pulmonary vein, right upper pulmonary vein mapping, roof of the right pulmonary vein ablation. So we can clearly see that we're doing things, we have good contact, we're not going in the veins, we are causing tissue changes with our ablation process. So a lot of accuracy. It's really not a blind procedure. A lot of people ask, what about esophageal monitor? Can you see probes? Can you monitor esophagus? Yes, absolutely yes. Here is the left atrial cavity. Here's the esophageal probe, the circuit catheter going down. We count the probes and make sure that with the middle probes are in a position to the left atrial posterior wall. Here you can see the serpentinous form of the circuit catheter, and the esophagus is close to the left pulmonary veins. So we can clearly see that we are okay, and our probe is in the right spot to monitor esophageal temperature. Also, very important is the formation of thrombus and checking for complications during procedures, and eyes and ultrasound is the only way that we are able to see that. So if you're using fluoro and if you're using 3D mapping, there's no way we're going to be able to see thrombus without ultrasound. So this is the way, this is the duodecapolar catheter in the SVC, and this is the thrombus forming there. The thrombus keeps growing and growing until we decide to try to retrieve the thrombus with the sheet. Sorry, I had an issue with the PowerPoint. I'm trying to go back, reopen the presentation, go back to where I was. So in terms of complications, it's very important that we check for pericardial effusion. Again, ultrasound is much better than seeing the silhouette on fluoro. This is a normal silhouette. This is an anterior pericardial effusion. This is a posterior pericardial effusion. In fact, if you're talking about perforation, there's nothing better than ice to avoid that. This is a study published this year of 102,000 patients showing a relatively low incidence of perforation overall in the US. But you can see that in contemporary era, ice non-use is the single most important predictor of perforation. It increases the perforation risk by almost 5 times as compared with you're not using ice. So I conclude saying that zero fluoro ablation is important. Why? Because we need precision, and it provides precision to our procedure. When? Always. We have less complications. We know what we're doing. We see everything. It's not blind at all. How? You have to change your mind. You have to rely on other methods, learn how to use them at their best. This is the combination of 3D mapping and ice, as I showed before. And you don't have to do it from day one. You can actually start reducing fluoro, becoming more comfortable in these other methods until you become a zero fluoro ablator. But it's very, very doable. And I think this is an inevitable change to the future. Thank you very much for your kindness and attention.